Afternoon, everyone. We start with the class after the testicular swellings with something called as testicular torsion. Now, the word torsion technically means a twist along a vascular pedicle, particularly is described along a solid organ along a vascular pedicle. Now, the same thing, example being, if you have a splenic artery and this is the spleen and you have a splenic artery, this is called as a splenic torsion. Okay. So, like you have a testes, as we shall discuss, is a testicular torsion. A parallel word, if you use it, is a volvulus, which is used for a hollow viscous. Example being, you have heard about the term intestinal volvulus, etc. So, there is a basic difference between the terminology, a torsion versus a volvulus. Now, we'll talk about testicular torsions, and as I've said, testicular torsions are a twist of the testes along the vascular pedicle or the torsion of the testes along the vascular pedicle, which in this case is the spermatic cord of the testes. Now, when we talk about this one, let us be very straightforward, and then let us talk about what are the important things that you should know for an exam. Now, to start with, as I've said, the first is the pathology about why does a torsion happen. Now, when you talk about the pathology on why does a torsion happen, what is important is that a testicular torsion, please remember, a testicular torsion is known to happen either due to an extravaginal cause or an intravaginal cause. So when you talk about the pathology, sorry, right, when you talk about the pathology, you can have an extravaginal cause, sorry on this one, right. So this cursor sometimes does not help me. Now, so you have an extravaginal cause, you have an extravaginal cause of a torsion and an intravaginal cause. So let us start with this one again. So extravaginal cause and an intravaginal cause. Now, before I speak the words further, let me be very clear with this word. This is the testes, this is the epididymis, and this is the spermatic cord. Now, the minute I talk about these ones, what becomes important for you to understand is that there is a thin layer, looks like a mesentery, that brings the blood supply from the spermatic cord with the testicular artery and the epididymis to the testes. Now, this thing that I've shaded in blue will be called as mesorchium, which means basically the mesentery of the testes, which brings the blood. As you can see, the mesorchium of the testes looks like north upwards, epididymis, testes, and the spermatic cord, which is this is the normal orientation. Now, talking about intravaginal and extravaginal again. Now, the word vagina in this case will always mean the tunica vaginalis and is responsible for covering the testes exactly like this. So, you have a parietal layer of the tunica and you have a visceral layer of the tunica. Now, anything that is happening inside this one, now this is an important one. Anything that is happening inside this is called as an intravaginal torsion, whereas anything that happens outside is called as an extravaginal torsion. Now, can you look at these pictures again? So, this one is an extravaginal torsion of the testes. Look into that the twist has occurred outside the tunica vaginalis, whereas if you talk about an intravaginal, as you can see, everything is in the tunica vaginalis, that means the cover, and the torsion is occurring into this. So if you have understood these two, the basic understanding of a testicular torsion is done. Now, followed by these ones, there are some other ones which needs to be understood by you, and these other ones includes rare problems like something called as a mesorchial torsion, which remember is a type of intravaginal torsion. Rare ones, intravaginal torsion is not on the testes but on to something called as appendix of the testes or appendix of the epididymis. So there are four types of torsion that you are required to know. What are they? Let us have a very quick recap. One is something called as an extravaginal torsion. Number three, a type of intravaginal torsion is called as mesorchial torsion, and then testicular appendage torsion. But remember that this is basically a type of intravaginal torsion, and both of them are clubbed under the single heading. This one is a very special subset where you clinically cannot distinguish between them, and extravaginal torsion is a rare one that occurs in neonates. Now, after we've discussed about this, let us talk about one by one with the clinical features and the pathology. As I have said, the most common one is always an intravaginal torsion that occurs. So, the most common variety of a testicular torsion is called as an intravaginal torsion. Now, let us be very straight again. Why does an intravaginal torsion happen like that? Now, when you talk about an intravaginal torsion, please remember there are usually three causes that will make an intravaginal torsion happen. The first cause is that the testes and this one, so as I've said, something called as inversion of the testes. What do you mean by this? Now, normally, as I've said, this is the epididymis, this is the testes, this thing that I have shaded, just give me a minute. Yeah. No. So, this thing is the mesorchium, and if this is the mesorchium, then from the mesorchium, you have the spermatic cord which is coming. Please see that this is normal in that. Whereas if the testis is just like this, transverse, this is a spermatic cord, or the testis is somewhat like this being the epididymis and this being the spermatic cord. Just give me a second to draw the mesorchium in this one. And as you can see, this is the mesorchium and this is the mesorchium in this. So please remember that. So this is the mesorchium and this is the mesorchium in both of these. And this type of mesorchium in which is an abnormality. So this is basically a normal, whereas these findings are abnormal finding. Now the first picture or the upper picture that I have drawn is very commonly asked around that and is called as a bell in a clapper deformity. So if someone asks you what is a bell in a clapper, now if you have gone to a temple, if you have seen again in a temple or a church, you will see a bell which in this case is the tunica vaginalis. And then in that you will see the testes. So now the clapper, which is the clapper. So please remember that if you have seen such bells in churches and temples, the place of the worship, now you will see that. So this is called as a bell in a clapper deformity. And this is said to be the most common cause. Why does an intravaginal torsion happen? Now, the second one, as I've said, is technically called as a bell clapper deformity. I've already mentioned that. And the third one is the separation of the epididymis, the separation of the epididymis from the body of the testes. Now, that also means that as I've said in all the pictures, epididymis and the testes should normally be friends together. What if that this epididymis, the testes, and as I have said again, your mesorchium are very different? Then what technically happens is this mesorchium is pretty long in one. So please remember that this mesorchium is pretty long, and that is the three reasons why does an intravaginal testes happen. Now, so this is all the things that predisposes to an intravaginal torsion. I will be erasing this. Now, question is that with these problems, why do you at all have that? Very simple. Intravaginal torsion or intravaginal torsion, remember, are usually seen in boys in the age range of 10 to 25 years or 10 to 20 years is approximately the age at which an intravaginal torsion is seen. Now, because of this problem, this bell and clapper and all these things, what happens is young boys at this age are known to have a strong pull by a muscle called as cremaster in the inguinal canal. You know that. That cremaster is a very strong muscle around the spermatic cord, which pulls the testis up, and then the sudden contraction of the cremaster muscles will be enough to pull it. Now, these cremaster muscles, as you know from your operative surgery, are spiral fibers. Now, these spiral fibers, what we do is that it will pull the testis upwards, and the testis inside the tunica vagina undergoes with these forms of deformity around. So, what I have done is that I have done a wrong picture. So, this is your picture that I have drawn, and then with these pictures, please appreciate this one. This is your epididymis, and this is your testis that is there, and this undergoes a torsion in this direction. So this is what you are required to know in this one. So again, 10 to 20 years cremaster contraction and intravaginal torsion is most important. Now let us talk about what are the clinical features then that arise due to a testicular torsion. Now, as I've said, intravaginal torsions are seen in age group 10 to 25, can also be seen in adults, but is usually uncommon to be seen. Remember that undescended testes, if I've seen my undescended testes class, I have said that undescended testes makes attachments very easily. Intravaginal torsion, the more common clinical features and which is more or less the same as an extravaginal torsion, is the same as a mesorchial torsion, is the same as a testicular appendage torsion. That means in all, the clinical features are indistinguishable except for the age group that we'll talk. Now, the first of the patient, the first of the problem that starts with an viva question is a sudden, severe, agonizing pain that occurs in the scrotum and plus minus may radiate to the lower abdomen. Please remember this. This is almost always accompanied by nausea and vomiting, and thus, as you can see, can be one of the mimics even for an appendicitis if it occurs on the right side. Okay. Now, can be sometimes with an uretary colic that it is usually mistaken on the left side. But remember two important findings. What are they? Nausea, vomiting, which are almost always present, and a sudden, severe, agonizing scrotal pain. Please remember that. Now, when you examine the scrotum, what did you find? On examination of the scrotum, so for example, we have it on the right side, we find that the affected testes on the right side is riding high. Now, on affected testes is having a transverse lie, whereas the normal testes has a vertical lie. Please remember that this affected testes is lying vertically. Oh, sorry, the affected testis is lying transversely and is high and is said to be vertical placed. Sorry, understood. Sorry, is said to be higher than the opposite side and is transverse in orientation. So please remember this one. So it is an high riding testis with a transverse lie. Now after this is done, what is important is that after this point is done, just wait on for a second. Okay. Now, so as very sorry for the interruption. Now, so as I've said that the affected testis is on the higher side and is transversely placed. Now, in this side, there is something called as a Friend's sign, now which is usually asked as a part of your viva question and as a part of an MCQ. What is technically called as a Friend's sign? Now, Remember that French sign is to differentiate between an epididymitis and a torsion testis. Now, in an epididymitis, the elevation of the scrotum will relieve the pain. That means if the patient was having a pain, elevation of the scrotum is going to decrease the pain a bit. In a torsion testis, remember, the more higher you make it, the patient will get more pain, and this one is thus seen on elevation of the testes. Now, there are other signs of concern, something that there are other signs of concerns, but what is important is this French sign is an important thing that is asked in MCQs as well as your MBBS classes. Now, after these things are done, what is important is the patient will have an absent cremasteric reflex. The patient will have an absent cremasteric reflex, and remember that later followed at the end of the day by having an scrotal edema if you delay it usually between 4 to 6 hours. The scrotum may have a red appearance, and thus examinations will ask you about what is your differential diagnosis of a testicular torsion. Now I will again make these points clear. What is your differential diagnosis about a testicular torsion? Very straightforward points. Please remember the most important points always of concern is always pain and nausea and vomiting. And if you remember this to be the most important cause, the rest of the things are very simple. The most common things that are confused with is a torsion with an acute epididymo-orchitis, French sign. Number two is, remember that before I go to the next one, sorry. Now, acute epididymo-orchitis is identified by presence of dysuria, fever, a duration that is usually greater than 12 hours, and French sign being negative. The most important DD, that is something that you should note. Point number two. The second point is a torsion of the testicular appendage. Now, testicular appendix is also called as a pedunculated hydatid of Morgagni. Please remember, it is also called as a pedunculated hydatid of Morgagni, and this one gives the same sign clinically. On doing an ultrasound, you get a sign called as a blue dot sign. You get a sign called as a blue dot sign. That means clinically this is a sign, and the investigation of choice is always an ultrasound, which we'll talk later on, distinguishes between this one. Now, the next ones we have talked about an acute epididymoorchitis, we have talked about an testicular appendage whose torsion can always be there. The next one, as you can always imagine, is a strangulated inguinal hernia, which will have the same feature. It can be number fourth, an acute hematocele of the testes. Number fifth, it can be an orchitis, again like a mumps orchitis, which is always the same feature in the same age group, is a difficult one to distinguish. And remember, rarely you have a condition called as an idiopathic, rarely you have a condition called as an idiopathic scrotal edema. Now that's it. So these are the things that we have discussed. So what are the differential diagnosis? Acute epididymoorchitis, torsion of the testicular appendage, strangulated inguinal hernia are the three important things that you are required to say during writing a short note or during writing an examination. So with this, we complete all the things that you are required to know in clinical features. Now let's talk about the diagnosis. Now, when you talk about the diagnosis of a testicular torsion, remember the testicular torsion is always a clinical diagnosis, and investigation of choice is always in Doppler ultrasound if you have a Doppler ultrasound. Now, please remember the word is very important. Ultrasound, then it is better not to wait and observe, but to explore the scrotum and observe the finding and then take a final call. rather than waiting for the testes to get destroyed and then thinking about what can be the next consequence, the investigation of choice, as I've said, is always an ultrasound of the scrotum or ultrasound of the testes with a Doppler, which must be done to rule out a testicular torsion. Now, just give me a sec. I'm going to show you a picture about how does this thing exactly look like on doing a Doppler ultrasound. Now, on doing a Doppler ultrasound, as you can see, now I will increase the picture for you guys. So this is what a Doppler ultrasound looks like. Appreciate that in a case of a normal one, there are again blue and yellow and colors that you can see, which suggests that there is a central testicular blood flow. Whereas in a case of a testicular torsion, you can get to see that there is no blood flow in the central part of the testes. So there is no blood flow in the central part of the testes. So remember that is the most important part that you are required to know for your exams about as a diagnostic tool for a testes and a testicular torsion. Now, after you have discussed about this, what is the treatment that is done for this condition? Now, as I have said, the treatment for this condition is always, so that means if I've talked about what is this one, an ultrasound is done, so then let us talk about what is the treatment. The treatment is an urgent scrotal exploration, and scrotal exploration, always remember, is bilateral scrotal exploration, and the bilateral scrotal exploration must be done with a golden hour of 4 hours, maximum 6 hours, and with the toys. Beyond 6 hours, not better to do a prestige preserving surgery. It is better to think about an orchidectomy. Now again, talk about the time. Now, what is important is if the patient is within 4 hours of presentation, after the scrotal exploration, you find this to be a viable testis, okay, with a viable testis, and then what you should do is something called as an orchidopexy. Whereas on the normal side, again, it should also undergo an orchidopexy to prevent any future chance of a testicular torsion. Now, please remember the timeline of 4 hours. Please remember that you need orchidopexy even on the normal side to do that. Very straightforward things. What if the patient has come to you late? Now, remember that what if the patient, if beyond 6 hours this algorithm does not follow, what is important is in this one, do not go for a detorsion. The thing is very straight. If it is beyond 6 hours, do not derotate. Please go for an orchidectomy directly. Because remember that there are theoretical concerns. Now, you see the word theoretical, in which if you have done a derotation, there is barrier, and the blood testis barrier gets broken to produce an injury to the contralateral testes. Now, people will say that no, these are theoretical, may not have such problems. But again, remember that beyond 6 hours, it is not a wise thing to go for a derotation. Please think about doing an orchidectomy, and on the opposite side, do an orchidopexy. Now, what if you have other findings rather than having on a scrotal exploration? Now, after the scrotal exploration, if you have other findings like an infection, then you can either close and come out, or you can just drain in a purulent collection or pass. You can go in for just an eversion of sac if it is found to be an epididymitis. Examiners will ask you, what is this one? Again, the only procedure that you should require is drainage of the infected fluid. The procedure that we do is usually an eversion of sac. Why eversion? Because remember that this is the epididymis, this is the testis, this is the spermatic cord, this is the tunica vaginalis. The minute you have opened the tunica vaginalis, all these infected fluid comes out, and it is better to evert the tunica vaginalis out and the fluid comes out. Now, so this completes this next part also. Now, ending the topic with few notes around extravaginal torsion of this testis. Now, as you can see, extravaginal torsion is a very rare finding. An extravaginal torsion is a rare one and is usually seen in neonates. Please remember, and is usually seen in neonates. And due to this thing that is seen in neonates, what is important is that what is important are some people say that are known to occur before 2 years of age. What is important is with this picture, the clinical signs are the same as that one. What is important is majority of them will present after 4 hours, and thus, as I've already said, the chances of the treatment, as I've said, the chances of having and viable testes in this age group are very less. And please remember that are seen in the perinatal or the neonatal age group. So these are all the things to be talked about in this one. Now, before we finish up this topic, what becomes important is that what is the recent advances in thoughts that we have about testicular torsion. Now, the only recent advances that we do have is that if the people, if the child is less than 10 years, then please remember that alloimmunization, that means that blood testis barrier like thing is probably low. Now I use the word probably because there are books in pediatric surgery which have various opinions on that. And please remember that so if the child is less than 10 years, the recent advances is that if it is greater than 6 hours, maybe, now I use the word question, maybe you can think about a detorsion. So please remember that you may think about a detorsion, but definitely between 10 years plus, if it is greater than 6 hours, I will always go for an orchidectomy to preserve the opposite testis. So this finishes your testicular torsion. Testicular torsion is a very common short note that is given in examinations. Some cases they have given it as a part of a long question and as a part of a scrotal swelling. With this, thank you very much. We have completed the topic of testicular torsion.